Yeah, so no problem at all. It's a great pleasure of mine to introduce Mohamed Hassanein, who is Deputy Chair of the Congress and right-hand man for Professor Inas Jalkut. I've known Mohamed for many decades. We worked together for a spell of time, and we've been close friends since then. He is not just a friend in science, but also in health, in good health, in principle, and he is like a brother to me. So Mohamed is chosen one of the topics to discuss this afternoon. And as you are aware, he can actually be given any topic in diabetes and give an excellent talk each time. He never fails to impress and to deliver the messages. So welcome, Mohamed. His topic today is, which is more important, age or duration of type 2 diabetes? Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Mick. It's always a pleasure to have you here in Egypt and the conference, and thank you for this presentation. So I'm going to share with you some important data. Some of it has just been analyzed, some of it is about to be published, about the important topic of diabetes and cardiovascular disease, and the factor of when we are risk quantifying a person with diabetes, we think obviously of the classical risk factors: smoking, hypertension, hyperlipidemia. The issue of age and duration of diabetes have been gradually emerging, and the question really, should we really consider them or not? I don't think that you all have any concerns about the fact that why we are treating diabetes, we're not treating hyperglycemia. We are treating a condition that can lead to lots of comorbidities, specifically cardiovascular and renal comorbidities. And in the past, we always thought that a person with diabetes will end up being victimized by the fact that they have diabetes, and perhaps they will die younger or unexpectedly, prematurely before their maybe if they did not have diabetes. But this important data from the Swedish register, which I personally had the pleasure of visiting, this very impressive building of the Swedish Diabetes Register, a huge building like an institute with many researchers, and looking into this. And what they came in Sweden is, if we treat all the 5 main cardiovascular risk factors of a person with type 2 diabetes equally to the same targets, their outcome with regards to comorbidities or mortality would be no different than a person without type 2 diabetes. And this is very important because it gives hope to everyone, whether you're a clinician or a person with diabetes. Most likely, many of us in this room are both a clinician and a person with type 2 diabetes. Now, we all know the recent ESD ADA recommendations focus on this important factor. And I would like to highlight to you some of the important points. The importance of screening and surveillance. It's very important that we do not wait until the problems start. We need to search for the subtle markers of the conditions and screen them. And indeed, this is very important because not only we are treating aggressively the person with a pre-existing cardiac or renal problem, we are also treating people with indicators of high risk. So what are these indicators of high risk? So among the 2 important questions that I want you to think of, does age matter? We cannot fight age, but does it matter? And what age would be the cutoff age for saying you're at more risk? Does the duration of diabetes matter? Also, we have no control on this once it begins. Maybe we have control to delay it before it starts. Well, the ADA have specifically answered that point for one of them. And it said that, of course, for people with CVD and whatever, they have the event. But if you don't have the event and you have risk factors, they have specified what are these risk factors. And they said specifically the age of 55, as well as, of course, the obesity, the hypertension, the smoking, the dyslipidemia, and the microalbuminuria. The very recently published score 2 from the European Society of Cardiology, and I would like you to remember, I've shown you so far the American European recommendations, and now it is the European recommendation. And here they have specified age and in correlation with duration of diabetes, which is 10 years, more than 10 years or less than 10 years. So we now have indicators that duration of diabetes is important, and they have had a cutoff of 10 years, and age is a continuum. The ADA, along with the ESD, said above the age of 55. And the evidence for this has been many. I'm here showing you one study about this, looking into people with insulin-dependent diabetics, an old terminology for many people with diabetes, whether they are type 1 or whether they are type 2 dependent on insulin now. Anyhow, beyond the terminology, people with diabetes requiring insulin treatment, and they here identified the age at onset and the longer the duration of exposure to diabetes seemed to be in the study a very important risk factor for developing mortality. But this is American and European recommendations. We are here in Egypt and in the Middle East. So does it apply to the region? What are the recommendations that apply to our region? I had the honor to be a part of this very important recommendations between the cardiologists and the endocrinologists in United Arab Emirates. We produced this paper coming close to 18 months ago. It was published over a year ago. Along with Hani Sabbour, who is a cardiologist originally from Egypt as well, we are the first 2 authors for this important document. In this particular document, knowing the population that we have, we've recommended annual intensive screening. And you would see from this screening, it goes a bit beyond what is normally recommended in a comprehensive annual review. And of course, like any clinician, the most important factors are to quiz the person thoroughly, because the classic person with diabetes will not come complaining of crushing chest pain. Diabetes sometimes does not produce these classic symptoms. And the other factor in our region, yes, it is a document for UAE, but I don't think it's very much different in Egypt. What we realize that the sedentary lifestyle is very much in abundance, and people do not exercise. So classically, I would say I have shortness of breath on exertion, chest pain on exertion, or claudication in my legs when I walk. But if I don't walk very much, or if I don't exert myself, I will not get these symptoms. So of course we have to proactively screen to get and diagnose these people who have the condition but is currently asymptomatic because of their sedentary lifestyle. Now, if the person is screened negative, does not mean that they are low risk. Then we say, go again and risk quantify. And we have came up with this risk score, risk calculator, and we said age above the age of 40 or above, duration of diabetes of 10 years or above, and then the number of cardiovascular risk factors. We based this on the observations that we see from the community about the age of people who come with cardiovascular disease or similar conditions, and we decided that this is the appropriate age. The question is, are we right or wrong? Well, first, we have to understand our population very well. My good friend Tatiana have presented this morning, or not this morning, just the session before, about the overall prevalence of obesity globally. Regionally here, obesity is a very big factor. And unfortunately, as you can see here, this is obesity, overweight and obesity and normal weight. So green is normal weight, yellow is overweight, and red is obesity. And as you can see, it starts even in very young people in their 18 years old, early 20s and early 30s. So it's a problem that is affecting the whole population. Now, I would like to remind you, maybe those of you who have not visited United Arab Emirates or Dubai, the data are not for the Gulf person. The Gulf person in this data is less than 1/3. The data is from people like me and you and many other people from the Middle East or indeed from Asia. So it's a comprehensive data for many people from ethnic backgrounds. Now, when you look into prevalence of diabetes based on age, again, in the same country, based on studies that we have conducted, you all know, the older we get, the high likely that we will develop diabetes. That's a fact. But I want you to concentrate here on young people in their 30s and in their early 40s. 13% prevalence of diabetes in expatriates, non-Emiratis, who are living there in their between the age of between 36 to 45, so the mean is 40 years old. 13%, and even in people below the age of 40, they have 4.5% prevalence of diabetes. And that actually was higher than the Emirati. So if you're thinking that the Gulf is the wealth and the sedentary lifestyle and it does not affect us, you're wrong. It equally affects us exactly the same. And I will show you some other interesting data. When we looked into this, our recent publication earlier this year on pre-diabetes, and you can see exactly the same problem. 4% of people with between the age of 18 to 29 have pre-diabetes, and 12.4% in people in their 30s also have pre-diabetes. Of course, pre-diabetes is a cardiovascular risk. The risk does not start with an HbA1c of 6.5. The risk starts way before 6.5 of HbA1c. So if you were to add them both together and look into age, blue is diabetes, orange is prediabetes, and green is euglycemia. And you can see that even in people in their mid-20s to mid-40s, over 21% of them have either diabetes or prediabetes, which means 1 in 5 person in their 20s up to the mid-40s are either diabetic or pre-diabetic. That's a huge difference than my practice in UK when I was primarily seeing people with diabetes in their 60s and 70s and perhaps in their late 50s. So this is very different. Going again to another important prevalence of a cardiovascular risk factor, which is hypertension. We published this data about a year ago. And here you can see, again, hypertension according to age. So 30% of people living in their 30s are diagnosed with a blood pressure above 140/90. Whether they knew that they have hypertension before, or whether it is the current blood pressure reading. And even in their 20s, 20% are with high blood pressure. So what about Egypt? I've shown you data from Dubai, so you simply can say it doesn't really reflect on our community. So one best place to think and reflect is Aswan, and this is a beautiful picture from Aswan. Whoever has not been there, you should go. You really enjoy a very good quality time. This is the population pyramid of Egypt. And the population pyramid of Egypt is different than many other countries because, mashallah, we have very, very broad base. We have lots of children into the community. So when you add those together, people below the age of 20, 43% of the population are below the age of 20. Another 20% are between the age of 20 to 39. So if you think of Egypt's population below the age of 40, this is 63% of the population. This is very different from Western society's population pyramid, where we have a large number of people in the older age group and much less in the younger age group. MashaAllah, the country is very fertile in many ways. So it's important to understand our population because it reflects on what do we expect. What is the age of the person with diabetes I'm expecting to see in my clinic? This is a study that we've done in Alexandria. I was delighted to be a co-author with my colleagues, professors from Alexandria, about the prevalence of diabetes in men and women in Alexandria. Now, the beauty of Alexandria as a city, it has the inner city as a modern city, it has the agricultural surroundings, and it even have the Bedouin section, so it's more or less truly representative of the various sections of Egypt. And as you can see here, the prevalence of diabetes in people I've put here in the circle below the age of 40, that's not a small prevalence. 15% in the people in their 30s and a bit lower in their 20s. And obviously, when we get into the 50s and 60s, we are talking of over 40%. So my concern is not about the older age group. This is a fact that we know. My concern is about understanding the young population who will be exposed to the cardiovascular risk factors for 30, 40, 50 years or even longer in their life, which is different than if I'm diagnosed with diabetes in my 70s. This is data from the project of 100 million health, 100 million صحة, that the country has undertaken. And I have put it here, focus on the green rather than the comparisons of men and women. So current smoking, you've noticed it in the hotel and walking in the street. Smoking is massively prevalent. 22% of the population are smokers, specifically in men, 43%, and very little in women. But I would say a but here, but in our culture, not many women confess to being smokers. There is denial because it's not socially very much acceptable. So this 0.5% is probably an underestimation. Now, we are a country that produced lots of fruits and vegetables. And it's a shock to me to see that in a survey where people answer by themselves, 79% are not having the exercise, or, sorry, 90% are not having the 5 serving of fruit and veg. Although traditionally, our staple diet, which I grew up with, every day you have stew, khudar, and we have salad, and we have lots of fruits. But it does look like the society have moved into the fried food, the chicken and fried and the meat fried and whatever, and the rice and the fruit and veg have declined in the table of the classic Egyptian, and this is what been seen. So consequently, it comes as no surprise that 35% are considered to be obese, whether they are men and women. So guidelines have changed. Guidelines now, because of the cardiovascular outcome trials, have focused on specific lines of drugs, regardless of glycemic control. And of course, we need to take this into account. And when we produce any guidelines, we have to think of the primary care physician. The primary care physician who is very busy, whose consultation is very short because of the workload that they have. And obviously, we have to provide them with simple guidance rather than a complex guidance. And of course, the most important when we say to any person with any healthcare professional, when you're seeing a person with diabetes in front of you, assess their cardiovascular risk. So I'm going to share with you sub-analysis of data that we haven't published yet, but we've published the original document, but this is a sub-analysis that I have completed actually this morning for this presentation. So this is data of 12,500 persons with diabetes type 2 and 2,500 with type 1. We've published some of this data already, and this data are from many regions, including, of course, Egypt, and Professor Ines and many other colleagues have contributed to this data. We have over 1,000 persons from Egypt into this data. It includes many people from as west as Morocco to as east as Indonesia, and some European data as well from Turkey, and a very small data from UK. So many people simply have this statement: why do you calculate risk? Everybody with type 2 diabetes is a high cardiovascular risk. Is this statement correct or wrong? Obviously, when you talk to cardiologists, because they see people with cardiac problems, so they obviously are concerned. So to answer this question, and to answer the other questions, does age matter and does duration of diabetes matter? Now, I've told you already that we have advocated proactive screening because of the sedentary lifestyle in our community, because of the young age of prediabetes and diabetes, because of the level of obesity and hypertension and smoking. So we advocate proactive screening. But if you screen me and you prove that I have no end organ damage, then you will have to quantify for my risk. And as I'm showing you again, according to the quantification, to the risk calculation, you will have some people with moderate level of risk and some people with low level of risk. And some colleagues says, where are these patients? They do not exist. But actually, they do exist. So this is the data from the 12,500 persons with type 2 diabetes, including Egypt. And this is the data that the doctor in the survey said, my patient has none of the problems of hypertension, dyslipidemia, cardiac disease, renal problems, microalbuminuria, or full problems. My patient does not have any of this. And obviously this is related to age and to duration of diabetes. So if today I'm diagnosing a person in their 30s or their 20s, there is a chance that 27% of them will not have hypertension or dyslipidemia yet. Now, I would obviously need to warn you that the analysis does not include the obesity or the smoking questions, but we're talking about what already exists. So perhaps it's not none, perhaps it is one. Maybe they are obese or a smoker, or perhaps two. When you look into the correlation of age, is there a correlation of age with comorbidities and mortality and complications of diabetes? Of course there is. For every parameter, whether it is below age of 40, 40 to 50, or above, with every bar you would see the direct correlation to age. You know that. What about duration of diabetes? We've subdivided the group into less than 10 years, more than 10 years, 10 to 19, or over 20. And again, the same correlation. Even smoking, very interesting when you see the age correlation of existing smokers or ex-smokers. So people with diabetes, because you keep saying to your patient, stop smoking. So gradually, by time, they gradually start to stop smoking. So here you see 10 years, less than 10 years, high prevalence of smoking. And then as we move longer in duration, the number of people with diabetes who are smokers go down to the extent that at the age of over 50, 60 years, or over 10 years of duration of diabetes, it is less than 5% of people with type 2 diabetes are current smokers. What about macrovascular disease? The parameter that we assess the risk quantification. Does it matter which age? Specifically, is the age of 40 or 10 years duration of diabetes are a pivotal line? And you can see here, in green is people below the age of 40. How many of them have pre-existing macrovascular disease? 1.9%. When you go to the age of 40 to 50, it jumps threefolds to 5.6%. When you go to the other part of the screen, duration of diabetes, less than 10 years, it is 7.1%. More than 10 years, 10 to 20 years, it is 15.9%. But perhaps you would ask yourself, many people who are perhaps below the age of 40 or above the age of 40 might have long duration of diabetes or vice versa. So it's very much like the chicken or the egg. And this is really important for us to try to decide on which factor. So I've tried here to combine both the age and the duration of diabetes. In young people below the age of 40, it did not change very much whether they have diabetes for less than 10 years or longer than 10 years. But it's very clear to me that age matters when it comes to cardiovascular problems. There is a huge difference between people with the age of above 40, even if their duration of short. Of course, when you combine both, age above 40 as well as duration of diabetes above 10 years, this jumps to 8.9%. So clearly, in my mind, the problem that we have in our community is we have a high-risk population because we have many people with multiple risk factors, and they start at young age. Smoking is in abundance, obesity is in abundance, metabolic syndrome is in abundance. Screening is required, and we have to have screening methods because of the sedentary lifestyle that does not necessarily give people the classic symptoms of cardiovascular disease. We have people with young diabetes population at onset, and some are indeed with moderate risk or low risk because they start with diabetes in their 30s and even in their 20s, so they haven't yet developed enough morbidity with the condition. Age and duration are important cardiovascular predictors, and they need to be included in the risk calculation. And certainly, we need to have robust evidence-based medicine that is related to our population and not other populations that might not reflect our community. Thank you.
Thank you very much, Dr. Hassanein. I think in the sake of time, we're going to go to the next presentation, then we'll have some time for questions. Wonderful presentation about your work. It's very good to see this done, and it's very stimulating. I'm sure we'll have some questions at the end.